Thank you.
Good morning, everyone. Thank you, Scientific Committee, for giving me this opportunity. Today I'm going to talk about...
DUSN.
It's a DUSN. DUSN is a progressive ocular infectious disease caused by different species of nematodes that can lead to the visual impairment and blindness. It is a multifocal chorioretinitis. It was first described by Gass in 1978. There are multiple nematodes causing DUSN. Some of them are Toxocara canis, Balisascaris porcinus, and Ankylostoma caninum, and others. There are prognostic nematodes are divided based on their length. There are two types, small worm and larger worm. Small worm ranging from 400 to 1000 microns appears as white or yellow outer retinal lesions, tends to move slowly and has a slower rate of progression. Larger worm of range 1000 to 2000 microns appears grey-brown in color and moves faster and has a rapid rate of progression. There are risk factors. Predisposing factors include travel to or residence in place where causative parasites reside, and DUSN occurs most frequently in children and young adults prior to their fourth decade, more often in males than in females. Despite DUSN being mostly described as unilateral disease, rare bilateral cases are also reported in the literature. Coming to the pathology, the nematode eggs from the dogs or raccoons are ingested after they have been shed from their carriers. After entering the body, the larvae from the eggs hatch into larvae. These larvae travel hematogenously, migrate into the subretinal space where they may spend months or years without changing size or shape. These nematodes may invade cutaneously. It's the life cycle of Balisascaris. The pathophysiology. The presence of worm in the subretinal space causes gliosis and mechanical and immunomodulatory changes in the retina, that causing the damage to the retina and RPE. The association of worms migration through the neurosensory retina and toxicity of its secretions and the host immunological response leads to the toxic autoimmune nematode retinopathy. It has been suggested that outer retinal layer experiences a local toxic effect, whereas the inner retinal layer experiences diffuse toxic reaction. Then there will be infiltration of eosinophils, macrophages, and gliosis further leads to the ganglion cell loss. There are DUSN is characterized by two stages, acute or early stage of DUSN, chronic or late stage of DUSN. Acute stage is characterized by the presence of multiple evanescent, small, round, yellowish to grayish white lesions which appear in a small cluster or crop seen at the level of the outer retina, affecting the single quadrant at a time. After the worm passes to another area, these lesions will disappear and another crop of lesions will appear in the another quadrant. Commonly, the macular and juxtamacular locations are affected. Subretinal larva migration in the subretinal space produces subretinal yellowish white tracts or tunnels called as Garcia's sign. Larger worms are reported to leave tracts of clumped RPA as their footprints, and smaller worms are known to leave small chorioretinal atrophic scars. Patients in acute stage presents as asymptomatic or presents with central or paracentral scotomas, photopsias, or vision loss. Antiosegment is normal in most of the cases, but some cases presented with keratic precipitates and hypopyon, the literature. This is the picture showing yellowish crop lesion supratemporal to the macula, first picture. Second picture shows Garcia's sign, that is subretinal tracts. Later chronic stage of DUSN, there is vascular narrowing and progressive ganglion cell loss occur until the optic disc becomes atrophic, leading to permanent vision loss. There will be diffuse regeneration of the retinal pigment epithelium and enhanced retinal inner limiting membrane reflex, also called as orificin. Patients present with profound vision loss in this stage. Clinical diagnosis. There is diagnosis of DUSN is very crucial because only in 25 to 50% of 40% of cases worm is visualized during the eye examination. In case if it appears as a motile, coiling and uncoiling features. Identifying the larger worm is relatively easier with indirect ophthalmoscope, but smaller worm we should actively search for it with fundus contact lens or fundus photography. Some worm species are more photosensitive than others. It will help in moving the worm from the macula to the safer area where we can do photocoagulation. These clinical diagnosis is the presumed proper diagnosis. Other investigations will act as adjuvants. OCT in acute stage, we can see vitreous cells There will be retinal nerve fiber layer edema, which as a transitory edema, along with neurosensory detachment, shed photoreceptors, we can see a live nematode as a hyperreflective thing. Chronic stage OCT, we will be seeing retinal atrophy, thickness of the central macular. Fundus fluorescein angiography, in early stage, these crop of lesions will appear as hypofluorescent lesions. In later stages, there will be hyperfluorescent along with disc leak we can see. In the later stages, we will see diffuse choroidal hyperfluorescence as window defects. Visual field studies show different lesion patterns that cannot be correlated with the findings of the ocular fundus changes. ERG, B wave is usually more affected than the A wave, may present as a negative ERG. ERG will never be completely extinguished in case of DUSN. Indocyanine green angiography, dark spots can be seen in the early stages due to choroidal infiltration. These may persist or disappear in the later stages. Octa, we can identify the worm as far as it is motile because it's lacking vascular system. In the differential diagnosis, in earlier stages, it should be differentiated from the multifocal choroiditis, serpeginoid choroiditis, acute posterior multifocal plecoid pigment epitheliopathy, multiple evanescent white dot syndrome, and optic neuritis. The evanescent lesions in the mutes will disappear after a certain point of time and they may not appear in another quadrant. But DUSN, you will see the another few crop of lesions in another quadrant. In serpeginoid choroiditis, we should be as a DD in TB endemic country, but there are no evanescent lesions in the serpeginoid choroiditis, and there will be a scar with activity will be seen at the edge of the scar with or without hyperpigmentation. In the later stages should be differentiated from post-traumatic chorioretinopathy, unilateral RP, and occlusive vascular disease. Unilateral RP can be distinguished from the DUSN because of in DUSN there will be non-diffuse RP mottling and there will be absence of bony spicule pigmentation, there will be shiny ileum reflex, and ERG is never completely extinguished in case of DUSN. Coming to the management, proper management is direct nematode death by direct retinal photocoagulation. In case if worm is not visible, we can do retinal coagulation adjacent to the vicinity of the crop of lesions or sectoral photocoagulation in the periphery because it improves the drug penetration. Role of antihelminthics like albendazole we can give in case of after photocoagulation of the nematode or in presence of vitritis along with steroids to clear the media. In presence of vitritis, if worm is not visible, we can give albendazole 400 milligram or 50 milligram per kg body weight for 30 days. This is the flow chart showing treatment of DUSN. If worm is visible, we can directly do the photocoagulation. If worm is not visible, if any presence of vitritis, we can go for medical treatment like antihelminthics and steroids in case of vitritis after ruling out all infectious agents. In absence of vitritis, we can give medical treatment and scatter photocoagulation to improve the drug penetration. The take-home message, DUSN is a clinical diagnosis. It is important to know the stages of diagnosis because early identification and treating in the early stages will prevent progression to the chronic stage and profound vision loss. Early stage can mimic mutes and SLC, and late stage can mimic unilateral retinitis pigmentosa. ERG is rarely extinguished completely in case of DUSN. Treatment depends upon whether worm is visualized or not, whether we can go for photocoagulation or medical treatment.
Yeah, thank you, very nice this thing, but if you see the lesser aspects of the clinical presentations, very early stages, how do you suspect that this case can be a DUSN, not mutes?
These lesions won't disappear. These lesions will appear in another quadrant after some. They may fade away at that point, or they will appear in other quadrant after some point of time.
By looking at the lesion, we can't
By looking at the lesions, we have to find out the worm At the end,
No, worm, you already said it is 25%, a very high
yes,
percentage
yes.
actually. We have seen lot of cases, but 25% finding the worm is very, very high
Okay,
percentage.
sir.
You see the lesions at different stages.
Okay, sir.
That is one clinical clinching point that this case can be a DUS.
Yes.
Okay, and your laser, what I have seen is it's directly hit over the site of the worm.
Yes,
How
sir.
do you proceed? If at all you have seen a worm, how do you proceed with the laser?
We can directly hit the worm, head of the worm, or
That is what you should not do.
okay, sir.
Actually, it will immediately
can do-
migrate to the other. You cannot keep on changing. Any means, society mein we will first surround the
Surround
house,
with laser
surround the
and
house of the person whom you
to
want
prevent
to
the movements.
right. So surround the worm and then you can blast. Once it is surrounded, it will not migrate. Then you can keep this thing. And the oral steroids and antihelminthetics which you are starting, what precaution should we take before starting such a treatment?
Antihelminths for steroids. We should rule out other infectious causes to rule out
Which one mainly?
tuberculosis.
Helminth, I am not talking about tuberculosis. Okay, we are confining to DASN only. I strongly believe that your diagnosis is clinching actually. So always CNS involvement should be ruled out.
Okay,
Otherwise, these patients can go into convulsions and
Convulsions and seizures,
yeah,
sir.
problems can happen. Okay. With this, thank you very much for your presentation.